Okay, good. Okay, so to the basic sciences, this is going to be a little bit of an overview of some of the structure and the biology of cartilage, and then just a brief overview of some of the surgical strategies, how to get cartilage defects repaired, replaced, or treated. So first of all, this touch was meant to be given last week, sorry, 2 weeks ago, but I was just finished the stage here, 123 Ks, 2,350 meters of climbing, and I was a bit buggered. And then I had a quite a good excuse. The Wi-Fi in the B&B we were staying at was not working, so I couldn't give a boring tut like this after a stage like that. But anyway, we managed to finish. There's some nice shots, and across the finishing line, so it wasn't the total waste there. Okay, so I'm going to go over the structure and the function and a little bit about the metabolism of cartilage. A bit boring. Most of it's in the textbooks, but I suppose seeing someone else's slides sometimes makes you think about it more and understand it a bit differently. And then and then some of the regeneration strategies or surgical techniques there. So the molecular structure is very complex. You know, a lot of patients say to me, why can't in 2022, why can't we just like spray on cartilage? Why can't you just resurface my joints with some sort of material that's going to be a good bearing surface, have all the properties of cartilage with the same modulus of elasticity and the same coefficient of friction? But when you look at the molecular structure, it's actually extremely complex. And think of every single joint in your body, from your little baby toe and your finger to your hip joint and your subaxial spine, all have this complex structure for cartilage, made up mainly of proteoglycans, which is a protein core, and sugar chains linked to it, forming these proteoglycan aggregans. The sugar chains, chondroitin sulfate and keratin sulfate, and linked to a protein core called hyaluronic acid. If you can just remember that picture at the bottom, and if you ever have to talk through it in an exam or sketch it, just remember that structure picture. It's makes you understand it. Cartilage is around 60 to 80% water. It's obviously a little bit more hydrated at the surfaces of cartilage, so that's the articular side. In osteoarthritis, water content increases. In aging, water content decreases, water content of the cartilage. Collagen makes up about 10 to 20% of the weight of articular cartilage. That collagen is type 2, with quite a long half-life, very slow metabolism of that cartilage. Oh, sorry, of that collagen. And proteoglycans, although very important molecules, only make up about 10% of the weight of cartilage, but they give the main elastic and compressive properties. They're also negatively charged, so they trap water, and their mechanical properties are responsible for what makes cartilage cartilage and the good bearing surfaces that they are with the load dissipation and the shear, anti-shear properties that you get with cartilage. It's extremely smooth with a coefficient of friction of 0.002. That's close to having ice on ice as a coefficient of friction. And this in combination with fluid film, elastic deformation, and the influx and efflux of fluid make for this efficient bearing surface, which arthroplasty in some way, certainly of the hip, tried to replicate. And then the lubrication, which is just all sort of mechanical engineering terms, elastohydrodynamic, boundary boosted weeping hydrodynamic, really just means that fluid can move inside and into and out of the cartilage and respond to load and deform, but then return to its original structure, original form, as opposed to being permanently deformed. The cartilage, looking at it in transverse plane or sectioning, is even more complex than the molecular structure. And if patients quiz and ask, why can't you just replace that cartilage? I show them a picture of this multi-layered cartilage layer, where each layer has such different properties from the layer above and the layer below, with 4 complex zones. Where just below the joint surface, the cartilage is different with very horizontally aligned collagen, which is greater tensile strength. Cells are very superficial. Just hold on a second. I'm gonna just check these dogs out here. What's up? Come on. Sorry, my dogs are rumbling in the background there. Couldn't concentrate. So the cells at the surface layer are arranged in a very horizontal type of fashion, as well as the collagen proteoglycans. And in the zone 2 and zone 3, the transitional layer and the radiate stratum, it's a bit more haphazard. And then below the tide mark in the zone 4, the proteoglycans and the chondrocytes are aligned in a very longitudinal or vertical type of orientation, which oppose shear. And then hydroxyapatite crystals anchor the cartilage to the subchondral cancellous bone. So there's no ways that you can just sprinkle on some stem cells or chondrocytes and expect it to replicate or grow this complex structure again without either altering the DNA or the genetics of the local cells or transplanting cartilage from somewhere else. And you can't just to do that on a global scale is impossible. So about the chondrocytes, they make up about 5% of the net weight of articular cartilage. They're responsible for all the proteosynthesis, the homeostasis of articular cartilage. They synthesize the proteoglycans, collagen, and then, of course, certain enzymes that are responsible for the stimulation of growth factors and transport proteins, etc. They're derived from the chondroblasts, and they're least active in the calcified zone. They've got very large lacuna, quite actually easy to spot on immunohistochemistry. And these are because of their large Golgi apparatuses and protein synthesis cores. They produce other molecules like fibronectin and chondronectin and anchorin. So cartilage metabolism is ongoing. Cartilage, remember, is aneural. So cartilage doesn't hurt. If you have a painful joint, it's not the cartilage that's hurting, it's either the synovium or the subchondral bone. Cartilage is also avascular. So all nutrients and all passing molecules have to move in and out of cells or be transported either by endocytosis, like this, where by degrading cartilage is phagocytosed and then broken down into molecules by lysosomes and then reused, and cartilage constituents such as proteoglycans are made again by the Golgi apparatus and the endoplasmic and the rough endoplasmic reticulum. This is stuff from second year, but basically protein synthesis, and transported out of the cell again to maintain the homeostasis of the articular cartilage. So it's pretty complex there. With aging, things change. We all like to stay the same. Unfortunately, you can't inject Botox into our joints and our articular cartilage, although it would be nice. The cells actually become bigger, but they become fewer, become hypercellular. The stiffness increases, the stiffness of the extracellular matrix. Proteoglycans decrease in size and mass, so they're not able to trap water as well. So it becomes a bit dehydrated, become less elastic, and then of course the subchondral bone is under more threat, more stress. causing subchondral failure, subchondral microfractures, and then onto osteoarthritis, in which case the water content increases. Just by way of messaging, on the surface of the chondrocytes, there will be ligands or receptors that we try and target with biologic treatment. So, and of course, your body is performing its own biologic treatment, but to try and manipulate this with PRP or stem cell therapy or BMAC, bone marrow aspirate concentrate, all are trying to affect this ligand or receptors on the chondrocytes to try and make more extracellular matrix and improve the transcription of the nucleus to make more protein for the surrounding cartilage by the chondrocytes. So that's really what's trying to be targeted with all sorts of biologic treatment. But it's much more complex. There's a lot of different growth factors and messengers: bone morphogenic protein, insulin-like growth factor, fibroblast growth factor, and all have different sort of effects on the chondrocytes. What about if there's trauma or damage to the cartilage? Trauma below the tide mark has limited ability to heal because there's very little ability for any diffusion from the synovium and from the fluid within the joint, and there's no blood flow from the subchondral bone into that cartilage layer just around the tide mark area. The only time that there can be some sort of healing is when there's penetration into the subchondral bone and release of mesenchymal stem cells, which is what I'm going to go into in one of the treatment options with marrow stimulation, where pluripotential stem cells or bleeding causes release of these cells and perhaps differentiation into fibroblasts, and then type 1 collagen is laid down and you get some sort of scar tissue or fibrocartilage. We know that joint motion benefits proteoglycan significantly, and immobilization for long periods decreases proteoglycan synthesis. When you think of the joint, you must think of it as an individual organ, or obviously in the body there are multiple organs, and there's a homeostasis to every single joint, and that's maintained by the synovium or the synovial lining, by the synovial fluid and hyaluronan, and then of course the cartilage chondrocytes themselves, and all have multiple growth factors released and accepted on their ligands, and influence the homeostasis of the whole joint. So an injury in one part can mean it affects the entire joint. And that's why when in some cases you'll have a patient with an osteochondral lesion of the knee, a small area with some localized inflammation, but they'll have a significant effusion, or they'll have synovitis around the whole knee or the whole ankle from a simple small cartilage defect. Just a repeat of that cell. So when you think of of a joint as a organ with so many processes going on, then you begin to understand what happens with repetitive injury or repetitive trauma in, let's say, an ACL deficient knee or a very unstable ankle. Whenever there's an injury or there's an intra-articular hemarthrosis, there's release of or bleeding into the joint, release of hemoglobin causes metabolites to be released, and activation of macrophages, and these produce metalloproteinases. Metalloproteinases are toxic to the joints. They decrease chondrocyte activity. They also decrease chondrocyte differentiation and decrease proteoglycan production. So these are not good for joints. MMMPs 2 and 9. So let's take another condition, hemophilia, where patients have spontaneous bleeds into their joints. And if not controlled, that's their primary orthopedic problem, is end-stage hemophilia damaged knees and ankles and elbows from multiple bleeds causing release of these inflammatory cytokines. Also with trauma, if there's regular trauma to articular cartilage, chondrocytes can be crushed. There's some local chondrocyte necrosis after the trauma and release of tumor necrosis factor and interleukins. This normal apoptosis, so that's normal dying or the normal cycle of life of chondrocyte, releases anti-inflammatory cytokines. But when there's necrosis from either some sort of trauma and a sprain or an injury, it releases pro-inflammatory cytokines, tumor necrosis factor alpha and interleukin. And chondrocyte necrosis plus bleeding causes inflammation. Inflammation attracts the neutrophils. And neutrophils then produce these metalloproteinases and then continue to affect the chondrocytes and the extracellular matrix. And that might be okay, it's going to be arrested after one injury or two injuries, but if you start having multiple injuries, say in a very unstable joint, then you start developing changes to the articular cartilage. And then when you're unable to support the subchondral bone, when the cartilage becomes permeable and the fluid can get through into the subchondral bone and the subchondral bone plate develops fissures, fluid can get into the subchondral bone plate and start resorbing some of the surrounding subchondral bone due to the inflammatory process, as well as increased hydrostatic pressure, certainly in the ankle joint. And if you don't have a support of the subchondral bone, then the cartilage above it starts to fail, such as you get in these cystic osteochondral lesions, where sometimes there's a minor fissuring of the cartilage and then fluid ingress. And certainly in the ankle, you start getting this ball valve effect with increased hydrostatic pressure and these subchondral cysts, which become quite tricky to treat. And most of these osteochondral lesions are post-traumatic, but sometimes they can arise spontaneously. And the theory is that perhaps there's an initial avascular insult to that subchondral bone, and then failure to support the overlying cartilage leads to these complex osteochondral lesions. So that's a lot of the sort of technical side and the theoretical side. What about repairing cartilage? Well, our goals are to obtain mechanically functional tissue repair, and the ideal would be to replace missing hyaline cartilage if there was a defect. We want it to be long-lasting, to be able to last the patient's life, or at least until the stage that arthroplasty or something more reconstructive is applicable. We want it to be durable, and then it needs to incorporate into the surrounding cartilage and be similar to the surrounding cartilage. And it's almost impossible to achieve all of those with the cartilage repair. So cartilage repair centers around 4 treatments, really. So simple. Either to stimulate the bone marrow, to transplant cartilage, rob Peter to pay Paul, get it from somewhere else, or to grow chondrocytes and hope that they then can form their own extracellular matrix and anchor properly to the subchondral bone, and in using allograft. Now, allograft is tricky, and I'll show you some examples. In South Africa, getting allograft requires it needs to be fresh, so the donor needs to be dead for less than 28 days, and it needs to be stored in an appropriate temperature. And we don't have the facilities in South Africa. There is a way of getting it from Belgium or the UK for these bulk osteoallograft transplants. I'm not going to really spend too much time on that. When it comes to the decision making about what sort of cartilage repair a certain patient might require, you need to take a look at these points. One, whether it's a primary or revision surgery. So in most instances, if the lesion is reasonable size and depth, one would attempt perhaps a marrow stimulation technique. But if it was a revision situation and the marrow stimulation or microfracture had failed, then one might want to pursue another treatment option. And the size of the lesion, we certainly know in the ankle that if a lesion is bigger than, or in the talus, if a lesion is bigger than 150 square millimeters, that marrow stimulation benefits are certainly much reduced, and that perhaps you would think about some other sort of cartilage transplant. And what about the location? Certainly, if it's very easy to get to and treat with a certain technique, then you may use that. Say, in certain places, you might need to perform an osteotomy to do an Oates procedure or transplant, which is quite invasive. So then you may err on trying marrow stimulation first and seeing if that works, as opposed to the invasiveness of performing an osteotomy to get there. You got to have a look and see. Sometimes these cartilage defects are not entirely cartilage defects. They're occasionally subchondral cysts with intact cartilage, in which case it's actually the subchondral bone that needs treatment. And you may then just need to perform what's called retrograde drilling or bone grafting of these subchondral cysts and leave the cartilage alone. Other things to take into account are alignment. So certainly with lesions in the knee and the ankle, if there's a malalignment issue, you may want to consider realignment surgery, such as an osteotomy of the calcaneus, to offload that damaged cartilage. Certainly if you're going to do complex cartilage restorative surgery, then you don't want to have that added axial load, certainly if it's gross. And then you want to look at what graft you have available. Of course, if you're in San Diego, where I know the guy that works there uses a lot of osteoarticular allograft. He's got a whole allograft bank that just gets recycled as soon as those Americans die. They just put new ones in there. So he's got this, and he's got great access to all this fresh allograft, which is disease-free and irradiated or whatnot. Then you've got to look at where you are in the world. I mean, here in South Africa, that's just not feasible. And performing MACI or AC or growing chondrocytes is very expensive. We don't always have that technology here, certainly in the state sector. Even in the private sector, those treatments are difficult to come by in South Africa. So you look at all of those options and see how you can best treat these patients. So microfracture is usually the first line of treatment for a smallish lesion. It's technically quite easy, depending on where it is, but burns no bridges. It's pretty low cost. It also has very low morbidity, and it may work. You know, remember what I said, that articular cartilage is aneural, so the pain is not coming from the cartilage, it's coming from the subchondral bone. So if you can arrest that subchondral bone edema, or arrest the subchondral hypertension or fluid ingress in some way by forming some fibrocartilaginous cap, then you're going to go a long way with treating these. Certainly in the upper limb osteochondral lesions, they respond very well in the most with marrow stimulation. First described from Stedman Institute in the knee and used in multiple joints now. But the problem is that differentiation of the mesenchymal stem cells into fibroblasts means that the collagen is type 1. Doesn't have the same properties as hyaline cartilage, and of course the results might tail off there. Well, it certainly does tend to work in smallish lesions, up to 85% good results at 2 years, but then longer term studies seem to show some sort of tail off for slightly bigger lesions, in that the results change. That 5 and 10 year studies showing that maybe it's not all as good as it's made out to be, and perhaps we should be thinking more about either adding biologics or improving the differentiation of the mesenchymal stem cells, or of course doing some more complex cartilage transplantation there. So autologous chondrocyte implantation is quite theoretical for most of you guys and myself. I mean, I haven't really tried it, but the theory is that you need 2 surgeries. You need to harvest some of the patient's own chondrocytes and then grow them in a petri dish or in a culture lab, and then implant them into the cartilage defect, and then hold them there somehow, usually with some sort of membrane, either using a fascial flap stitched on there or one of these other synthetic membranes, and then hope that they then can make some sort of extracellular matrix. I certainly know the results from some studies in Italy and in Germany, showing really good results with regeneration of hyaline cartilage, and using MRI T2 mapping, which is a special sequence of cartilage imaging, showing great regeneration of type 2 collagen and hyaline cartilage. So I certainly think that this is an option if you have the facilities and the costs are not prohibitive. It does mean 2 surgeries. It's the first look, and then harvest, and once you have enough chondrocytes, placing them back in there. And it may in the ankle mean an osteotomy to implant it. But certainly, I think, has a role to play. The other thing is, if there's a large cystic component, so the subchondral bone is defective, then you're going to have to fill that subchondral cyst with bone graft and then place the chondrocytes that you've cultured on top of that. Chondrocytes are not going to be able to fill a bony defect, which some of these osteochondral lesions certainly are. And then Oates' technique, robbing Peter to pay Paul, is sort of my go-to for large lesions, cystic lesions, lesions that are that have failed a microfracture, lesions that are relatively contained, so that you're able to get a mosaic in there or mosaic-plasty. And it means taking, certainly if it's an ankle lesion, taking a cylinder of cartilage from the ipsilateral knee, which of course is one of the downsides with an arthrotomy of in many instances a symptom-free knee, and in 12% of cases the patient may need to chronic knee pain, which is a bit of a problem. It's reported in the literature about 12%. But then you're potentially putting really good hyaline cartilage with subchondral bone into the defector. The problems, as I said, knee pain. There's an issue with some containment. If it's on the shoulder of the talus, can be tricky to contain and a lot of them are, to contain that cylinder. And the shape of the cylinder is usually convex. So you have to harvest it from the convex side of the lateral femoral condyle to make sure you try and match that medial lateral talus shoulder. So it can be tricky technically and getting the depth right. There's always a layer of fibrocartilage at the interface between the graft and the host cartilage or the native cartilage. There's some breakdown there sometimes. And then certainly with transplant into the talus, the articular cartilage in the knee is much thicker than that of the talus. So you have also different wear properties. The talus has thinner cartilage, but is much more load resistant. So the cartilage from the knee might not be able to take those sort of high impacts and axial load. So lots of different things that play roles. But certainly the AFS scores and the ankle function seems to improve a hell of a lot once you get a patient that's really symptomatic from one of these lesions. The other problem is that you have to get orthogonal to the lesion, and many of them are on the equator that require a medial malleolus osteotomy. In treating osteochondral lesions of the knee, you obviously don't need an osteotomy, but some of them can be quite tricky to get 90 degrees too, if they're quite posterior. Okay, and then just a short note on osteoarticular allograft. This is how this is a case that we did in America. We were able to get a cadaver, 26-day-old talus, and we were able to get these nice mosaics to fill a cystic osteochondral lesion. And obviously then you have the freedom to fill any sort of defect. Even getting a bit radical, this is like a total ankle replacement or total osteoarticular allograft transplant that the guy I know did in San Diego. Yeah, that's about all for cartilage repair and regeneration, guys. So basically, if you keep it quite simple, think of those 4 surgical techniques. There is another option that certainly is not available here, using fetal cells. It's called de novo, where in America they basically kill babies or babies that die, probably babies that die. They morselize their hyaline cartilage into small little granules, and then the theory being that their chondrocytes are extremely metabolically active, and then place those into cartilage defects with surprisingly, good results. But when you look at the literature and all of these things, you've got to take it with a little pinch of salt. Think of the 5-year, 10-year results, because the results at 2 years, 18 months, we know certainly with the microfracture weren't borne out, and they didn't have the same longevity as they preached initially after the good results of microfracture. So with microfracture, small lesions, less cystic, tend to do reasonably well with about a 75% improvement in scores and return to normal function. If they become larger than 150 square millimeters, then those results tend to tail off, and you might want to try maybe an Oates technique. Okay, that's the end of that. That's the end of that PowerPoint. Does anyone have any questions?
It's Bayanda here, Prof. I'm sure they don't kill babies, do they? For cartilage?
No. No, we were one of my colleagues who was developing the technique. We were ripping him off, saying, "Jesus, crazy country where you have the ethics to take cartilage from babies." But yeah, they would be donors, consented donors for sure. Yeah. Okay. If there's no questions, then I'm going to sign off there. Okay. Cheers, guys.
Thanks, Prof. Bye.